Welcome and thank you for joining us for today's webinar, Best Practices for Reducing and Controlling Healthcare Costs, presented by an esteemed panel of industry experts. I am Derek Holt at ABC National, and I will be your facilitator for today's webinar. Today's presentation is being recorded and will last approximately 60 minutes. This presentation will be available on ABC's website within 24 business hours. Attendees will also receive an email with the link to the presentation and a webinar recording. As per ABC National's AI policy, the use of AI tools that record virtual meetings, such as this webinar, are prohibited. Please note all participant lines are muted. You are welcome to submit questions throughout the webinar by using the question box located at the bottom of the sidebar. We will get to as many questions as possible during the Q&A portion of the presentation. You may also minimize and expand the GoToWebinar sidebar by clicking on the red arrow in the top left corner. I would now like to kick off today's webinar and introduce our speakers and moderator. Today's webinar is moderated by Madeline Ignash of ABC Insurance Trust, and our panelists are Adam Bonsky of ABC Insurance Trust and Dan Burke of Turner Industries Group, LLC.
All right, thank you, Derek. Ready to go, Dan?
I'm ready, Adam. Let's do this.
Let's do it. So, as Derek said, I'm Adam Bonsky. I'm the CEO and president of the ABC Insurance Trust. I've been in the employee benefits industry now for 32 years. About half of that time I've spent specifically working with contractors and their unique challenges when it comes to employee benefits. And during that time, I've worked for large banks and insurance companies, third-party administrators, a healthcare startup at one point, and over the last 4 years now with the ABC Insurance Trust. Joining me today is Dan Burke. Dan, you want to introduce yourself?
Absolutely. Thank you, Adam. My name is Dan Burke. I'm the Vice President of Corporate Benefits with Turner Industries Group. We are an industrial contractor headquartered in Baton Rouge, Louisiana, but operating in 30 plus states and soon to be internationally. We primarily serve the petrochemical and the energy sector. And right now we have just over 20,000 employees. And prior to my time at Turner, I functioned in the benefits management arena with Raymond James Financial in St. Petersburg, Florida, Parsons Corporation, also in the engineering construction business. And really my focal point, like Adam, I've been in the benefits business for 30 years, and this is my 30th year. And my focal point has really been trying to find innovative solutions to improve the cost and quality of care received by patients and employees. A lot of that has to do with innovative partnerships, combining approaches with consultants and providers and the employer community. And some of my volunteer experience includes the Louisiana Healthcare Quality Forum. I'm the board chair for that organization, and the Employer Coalition of Louisiana, which seeks to generate collective influence from the employer community. So I'm excited for today's talk and look forward to the conversation.
So Dan and I have gotten to know each other now, I think over the last year or more, somewhere's in there. And we've found one sort of distinct thing that we have in common. Of course, aside from our hair-free approach to life. It sounds kind of self-serving, but Dan and I have found this passion around making sure that contractors get the kind of information they need to help not only manage their health plans, but figure out ways to offer those health plans at lower price points with higher quality care, more proactive care for the workforce. And so Dan and I are starting a roadshow together. This is the first of many times he and I will be presenting this content to ABC members and maybe even CFMA next year, but you'll be seeing Dan and I doing this many times over the months to follow. As for questions, we are gonna take questions at the end, but if there's just something you're stuck on, please put it in the chat and Maddie will call us out and we'll answer it. This webinar is being recorded, so there'll be a copy of that recording available afterwards. In the way of a quick commercial, the ABC Insurance Trust has been around since 1957. It is a members-only benefit that specifically provides members with access to unique healthcare plans, dental, vision, life, disability, those types of insurance plans as well. We help contractors with their retirement plans, with individual plans like FSAs and HSAs and ICRAs. So really anything under the employee benefits sun, we've got a solution for members. And really any size member can come get help from the trust as well. It's a particularly tough time in the healthcare industry. Costs are rising dramatically, and we're expecting that to happen again here this year. So as renewal time is approaching and you're looking for help, please consider dialing up the ABC Insurance Trust. So with that, commercial is done. Let's dive in, Maddie. Next slide. We're going to start off by talking about the state of healthcare today. It might get some of you somewhat upset to hear what we're going to share. Consider Dan and I the messengers, if you will. We hope that even though it may get you upset, it will also provide you a deeper understanding of what's causing the rapid increase in healthcare costs and what are some ways, potential solutions that you can use to bring down that cost for you and your workforce. Now, according to the Kaiser Family Foundation, about 60% of the construction workforce is a participant, or they are participants in a self-funded plan. So that may be a surprise to you, but a lot of the industry has a self-funded plan in place for their workforce. So we're going to talk about those. That could be a whole slide deck by itself, but we'll just touch in a few areas. We'll talk about medical cost containment and pharmacy cost containment. So as Dan well knows, and many of you know, 90% of the cost in your health plan comes from hospital care and pharmaceuticals. And what can be frustrating about that is usually less than 10% of your workforce is driving that 90% of your cost. So the upshot there is you've got 10% of your workforce to focus on to bring down that 90% of your cost. So we're going to talk a lot about that. And then last but not least, we're going to talk about member advocacy and their experience with the health plan, with a main focus being on how to help them find lower cost solutions that are high quality and maybe even a no cost or no out-of-pocket cost for the employee at the same time. So moving on, next slide. Now, remember, Dan and I are just the messengers, and this is going to sound like a disclosure for a drug commercial at night, but this data may cause anger, depression, IBS, heart palpitations, who knows, but again, we're just trying to present to you the information as we have it. And keep in mind, over 60% of the people in this country who are covered by insurance are covered through their employer. So we as employers have a responsibility, I believe, and I'm sure you believe too, Dan, in fixing this system ourselves, being a part of the solution.
Absolutely. Yeah, and I believe that the best way for us to frame the first several slides of this presentation is enrage to engage, right? The information will not be news to a lot of folks, but it'll be shocking when you see the extent of the cost increases that everyone's experiencing.
So next slide, Maddie.
So this slide to me, Adam, is just staggering. You look at 2000, average annual salary, average cost of family coverage, and you jump to 2024, and it's gone up fourfold in terms of the average cost of family coverage, as opposed to, salaries haven't even doubled. So to me, this is really shocking, but as individuals, we've all become conditioned to expect regular increases in health costs that greatly outpace inflation generally or wage growth. But I think the slide is really illustrative of what companies and individuals are facing over a period of 2.5 decades.
Yeah, and what's sad too is the drop off in companies that are even offering coverage at all.
Yeah.
And I suspect that may continue because employers just can't afford it themselves. So next slide, Maddie. So the next several bullets, the data in those bullets are coming from the RAND group. The RAND Group is a nonprofit, nonpartisan research organization that attempts to drive public policy across the country, and they specialize in healthcare. I'll go through these bullets rather quickly, and then Dan's got some personal experience in working with the RAND Group himself at Turner. So a lot of this is the stuff that might make us somewhat upset, but maybe we already know. 1/3 of Americans have to take out a loan to pay for medical expenses. 38% of adults in high deductible health plans either skip or forego recommended care. So there was a lot of great ideas several years ago, 10, 20 years ago, about consumer-driven health plans and increasing deductibles and putting more of the choice in the hands of employees. But what we're seeing is that's not the full solution. Employees, when they have a $7,000 deductible, are going to stay away from those images or screenings that they might do because they are on the hook for thousands and they're sort of functionally uninsured. So there's more to it than just putting some of the responsibility on the employee to make choices. They need the tools. 52% of Americans feel stressed out about their medical bills. I don't have medical bills and I'm stressed thinking about it. Right? Since 2000, deductibles have gone up by 473%, and premiums have gone up by 355%. All of this, again, according to the RAND Group. While at the same time, during that same time frame, wages have only gone up 178%, and normal inflation was 167 during that time. Now, employer plans pay on average 254% over on top of what Medicare pays for the same services. Why is that? Why are private commercial plans, if you will, your plans paying so much more for the same services than Medicare? And in some states, like Florida and Georgia and others, you're paying on average 345% over what Medicare pays for the same services. So Dan, you've provided data and worked with the RAND Group, correct?
I have. Before I jump into that, Adam, you used a term that I think shows our advanced age, and that's consumer-driven healthcare, which was supposed to be a silver bullet 20 years ago. But as the data shows, people are scared of high deductible plans and really don't have the tools necessary to shop for care. It's not like you're buying a refrigerator or a car where you can research and compare the cost and the quality of the item you're purchasing. It's not as transparent as it needs to be. On the RAND Corporation, I've had the good fortune of being involved with them for the last 5 years. They conduct a hospital cost study that generates the data in that last bullet point. It uses Medicare as a benchmark and matches up prices at hospitals and health systems based on Medicare as a multiple of Medicare. This initiative was spearheaded by the Employers Forum of Indiana, which is a coalition representing employers, as an independent review of those costs and facility fees. Facility fees are a big component of the rising premiums. And it is, like Adam said, it's important to note that RAND is an independent think tank and it's not an industry representative of some sort. Also, the RAND Corporation does a lot of things in the think tank space. It's not just healthcare. They do military, political stuff, a lot of different things. So an independent voice providing information that is really useful to employers as you look at the difference in the cost of care based on where you get it.
So on the next slide, I think, Dan, you're going to touch on this one as well, is graphical version of the data we're talking about.
Yep, this really illustrates how cost shifting happens in healthcare. Right?
Yeah, that gap is significant, and obviously continuing to head in the wrong direction.
You see the increased deductibles, you see the increased premiums, which were carried over from the slide, whereas wage, what we can think about, back to the consumer-driven healthcare argument, consumerism just hasn't gained track, but the deductibles continue to rise. Sometimes employees with high deductible health plans don't even have access to a sufficient savings vehicle like an HSA or an HRA to help them manage those premium costs. So it's alarming when you look at this.
Next slide, Maddie. Okay, so Dan, I think you were did you have any comments on this one? I mean, this breaks down. Go ahead.
I do, yeah. And audience has to forgive us. This is our first shot at this. Adam mentioned we're going to do the roadshow, but we're just knocking the rust off today. When you think about Medicare, no employer thinks that hospitals should be paid at a Medicare rate, right? It's simply a useful benchmark. But that said, with the abundance of data now available through the RAND study, through such vendors as Turquoise Health, Sage Transparency, and others, it's clear that 275 and 300% of Medicare is not justified based on the hospital's own financial reporting. You can look up the 990 returns on the internet, and you can see that nonprofit health systems can be profitable at 100% of Medicare. Some are profitable under Medicare. But regardless of what you see there, I'm not advocating for paying health systems a Medicare rate, but maybe 150, 175% of Medicare is sufficient. What are your thoughts there, Adam?
Yeah, that's often what we see, around 120 to 150% of Medicare, unless you're going to go down to the cash pay rate, which we'll talk more about later, is where I see a lot of claims adjudicators or TPAs working to negotiate with hospitals. But some will, some won't, and we'll talk more about that in a couple of slides with one of the cost containment services that is available to plan sponsors today. And what's also, and I'll talk about this later, what's also of note is these are ERISA plans we're talking about, and therefore the costs of those plans need to be reasonable. And you're starting to see some employers getting pressure to say that these kinds of multiples over cost or over Medicare are not reasonable. And so as an employer or employers, we have a responsibility ourselves to continue to make sure that what we're paying or our employees are paying is reasonable under ERISA.
And as I look at the slide here in the states mentioned, I had some experience in Houston on the Houston Business Coalition on Health and their policy arm, the Texas Employers for Affordable Healthcare, which is a policy organization that really worked with state legislature in Texas to pass a bill, House Bill 711, which allows for employers to tier their benefits and provide information on transparency to steer care to lower cost facilities. So that's just to address the fact that you can make a difference at the local level and try and assist your employees in that fashion.
Next slide, Maddie. So this just shows the pain nationwide, right?
Yeah. Adam, have you ever seen a correlation between cost and quality when it comes to healthcare? I have not.
You would think that some of these facilities that have the big names would have the highest quality, but in many cases, I see sort of an inverse relationship with how much something costs at a hospital versus the outcomes. And that has a lot to do with hospitals not being the best place to do certain types of surgeries or to provide certain types of care. And they may not do very many, say, knee replacements. And therefore, they're not very practiced at it. And there's a lot of cross-contamination issues as well. And so there's a lot that's packed into it. But just because you pay more does not mean you're getting a better outcome in healthcare. And so the consumer has to shop for those providers that have good, consistent outcomes.
And I think it's important for us to acknowledge the difficult environment that health systems and hospitals are operating in, right? They've got staffing issues, they have financial issues. Rural hospitals are in real trouble for the foreseeable future. But from the employer's perspective, in my view, you should be seeking value being defined as cost divided by quality, right? And transparency has revolutionized a number of other industries. You think about, I'd mentioned earlier, shopping for a refrigerator or a car or a truck, airlines. You can shop online now, all these different aggregation sites, hotels, banking, retail, many others. And it's slowly, healthcare is late to the game, but we're slowly getting there. But what you've noticed, when information is more transparent, you have a more functional market, and the consumer experience in each of those industries is radically different today than it may have been 20, 25 years ago. But historically, healthcare is treated cost and quality as a closely guarded secret. And that really does have to change, because cost has a direct impact on a business's bottom line. And think about how difficult a business, what a difficult position a business finds himself in when you're looking at 10, 15% premium increases year to year. How can you grow a business when a big chunk of your costs are growing at that rate, right?
Yep. You're taking from one to feed the other, right? So
You are.
it's really lopsided. And we'll talk about pharmacy or pharmaceuticals later. There isn't a quality differential there. Typically, a drug is a drug, and so all the more reason to make sure you're not paying any more than you have to for it. But more on that later. Okay, so next slide. Speaking of pharmacy, if you all haven't heard the term, a PBM, or Pharmacy Benefits Manager, is the entity who's responsible for essentially getting the medications from the manufacturer through the insurance, if you will, to the employee or to the participant. The manufacturers of these medications aren't good at distribution, they're good at making drugs. And so that's where the PBM role stepped in many years ago. So there were good intentions to help more cost effectively, efficiently get medications out to people in individual products and in employer plans. Now, that control that was given to PBMs over the last several decades has given them quite a bit of power over what they charge, or what ends up getting charged for the medication, in this case to your health plan. So over time, they've become these behemoths, if you will, and in many cases might tell you that they don't charge any fees, but they make quite a bit off the markup on those drugs, or on the percentage that they charge over what the manufacturer charges for the medication. So we'll talk more about that. So that's where this sort of somewhat funny joke comes in. It's the perfect business model. They're responsible for, they're the consummate middleman or middle person. They're a part of what makes healthcare expensive right now. And President Trump made several comments recently about PBMs and how he wants to crack down. So we'll see. Their incentives just don't always align with yours. You want to get the medication at the lowest cost point possible, and they want to make as strong a markup as they can on the medication. So the trick is to find PBMs that will work on a fee-for-service basis. In other words, you're paying them a fee for getting you the medications at the lowest cost possible, as opposed to getting some kind of markup on the medication. And it's particularly problematic when you think about those PBMs that are owned by United Healthcare, Cigna, Aetna, because if they're owning the PBM, they're owning the distribution, there's not a lot of incentive to bring that cost down. And we'll talk more about that in a second. So next slide, Maddie. So for those of you who aren't familiar with a PBM, this slide gives you just a very sort of basic breakdown. Obviously, they're responsible for paying pharmaceutical claims. They handle the billing, consolidating the billing across all the medications for a health plan. They're helping check eligibility. They're explaining benefits. They're establishing the formularies that your plans use. So there are a number of things that a PBM does that are clearly of value in the value chain of getting medications to your employees timely, effectively, efficiently. There's value there. I think the question is how much should they get paid for that? Is what they're getting paid to do that job now a fair price and reasonable? So, and again, their interests aren't always aligned with yours, where you want the lowest cost and they want to have high margins. And as Dan knows, because I'm sure you've looked at this many times over the years, their pricing models, their fee models are quite opaque. It's really hard to make heads or tails of how they're making money and how much they're making off of each drug they're supplying to your plan. So Maddie, next slide.
Actually, let me chime in on that one for a second, Adam. I could talk about pharmacy and PBM all day. PBMs have received a lot of negative press, as a middleman between the manufacturer and a plan sponsor and the individual. And what you see as a person that handles benefits for a decent sized organization is that my read on it is that pharmacy benefit managers and pharmacy benefits overall are the ultimate shell game. Each year at renewal time, they'll come in and say, hey, great news, your drug rebates are going to increase twofold next year. Well, that's fantastic in that we're going to get some money back based on the drugs used on our plan. However, why can't I just get the lowest price available rather than playing the rebate game? And we're in the midst of an RFP right now for a PBM. And one of the requirements is that we've required them to be transparent. And that's something of an oxymoron in the PBM business, but the drugs that are driving the best rebates are the ones that are high cost and the ones you see advertised on TV. So as a plan sponsor, the best advice that I can give is since the passage of the Consolidated Appropriations Act in 2021, there's an increased spotlight on the fiduciary duty of a plan sponsor. And as it relates to PBMs, best advice I could give you is have your in-house counsel look at your PBM contract, have your benefits or risk attorneys look at your PBM contract, or work with a trusted consultant that has expertise in that area, because there's some risk in there and some things that you need to know that require an educated mind when you're looking at contractual language.
So Maddie, thanks, Dan. Next slide there. So I talked about this earlier, that the good news here is that we're not talking about all your prescriptions that are a problem, right? It's 7 to 10% of the prescriptions your employees take are driving 65% of the overall cost in your plan. So it's a handful of medications that are really driving up the cost for you and for all employer plans across the country. The top 100 drugs in U.S. sales and revenue combined in 2023 exceeded 240 billion. So there's a lot of money being made on these specialty drugs. And there are some questions right now about what tariffs are going to do to the cost of medications. There's still a lot of unknowns there. Dan and I were talking the other day that even generics are starting to go up in price. As many of you may know, most generics are made overseas, and a lot of the specialty drugs are made overseas, which then are brought back to the United States and marked up quite a bit more than what other countries pay for the same medication. So
yeah, that's a good point, Adam. And you think about Novo Nordisk, that is headquartered in Europe. I believe they manufacture Ozempic, which is already a costly drug and one that is hitting employer plans at a high level. And the ones that you see are the ones advertised on TV: Ozempic, Mounjaro, Skyrizi, Humira, Jardiance. You've got the cell and gene therapies out there that are treating rare diseases. Now, it's not going to hit an employer plan at a high percentage, but when it hits, it's going to be a 7-figure cost on an annual basis. You have cancer treatments, chemotherapy medications are incredibly effective nowadays as compared to 30 or 40 years ago, but there's also a price tag that comes with that. So it's important to keep track of that.
Yeah, and in so doing, think about how you're going to structure your plans, formularies, and what you're going to cover, because some of this stuff you're not going to be able to afford, right? So so next slide, Maddie. This sort of puts a really fine point on what we're talking about with PBMs. So almost 80% of the entire market share for PBM revenue comes from CVS, or is driven by CVS, Express Scripts, and Optum. So combined, they're making roughly $750 billion a year on their business. And a lot of times, Dan has seen this multiple times. I've certainly seen it. They say they have no admin fee, right? So when you hear no admin fee, that should make you nervous, right? That's a warning sign. That's basically, hey, they're making all their revenue and a lot of it on basically the way they mark up medications from the manufacturer until it gets to your employee.
One of the things we've seen, Adam, is, sorry to interrupt, is on the legislative front. In Louisiana, there was an effort to pass a bill in the last session to limit the ability of a pharmacy that owns a PBM to operate in the state. CVS is notable on that front. And I believe in Arkansas, that actually passed.
That's right. It did.
Yeah, so that's a trend. I think it brings to light the fact that PBMs are getting a lot of attention from lawmakers.
And worth noting, CVS is owned by Aetna. Express Scripts is owned by Cigna. Optum is owned by United Healthcare. So ding, 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 this is something to dial into. If they control the insurance and the distribution of medications and the cost for what those medications will be, then where are you in all that? How can you possibly have control or any kind of sway to make those prices for medications more competitive? It's all in the fix. It's all built in, right? So next slide. Dan, I think you're going to touch bases on this one.
Yeah, and these are the ones that I referenced earlier. Humira, Stelara, Ozempic. These are the ads that you see on TV, and these are some slick ads. These were not thrown together in a local studio. These are casted and shot like a Hollywood movie. But you can see the annual costs here and why they're doing the ads for these drugs. It's because there's a high ticket item. And as I look through my list of top drugs, I believe Humira is the most profitable drug in history. Humira's on there, Stelara, Ozempic, Skyrizi, Rinvoq, and Dupixent, not yet on my list, but I'm sure they're coming. And, I referenced earlier the cell and gene therapies as well that are going to impact a plan. But if you watch TV in the evening or the evening news or cable news, you've seen these ads on the regular.
Next slide, Maddie.
Rebates do matter. When I speak with my consultants on this topic for the last decade, it's been, man, I'm so tired of playing the rebate game. But at the end of the day, it lowers the total cost of your plan. I'd certainly love to be at a place where you can get the lowest cost price without a rebate structure. But for a medication like this on Rinvoq, which is $78,000 annually, your annual rebate's $24,000, which brings it down to $54,000. That's a significant incentive to continue down that path. And as I mentioned earlier, it's presented to an employer as, hey, good news, you're going to double your rebates this year. You may have $10 million in rebates. Fantastic. But at the end of the day, I'd rather have the lowest price, but rebates do help us manage the costs of a pharmacy plan, and we're able to pass those savings along to employees in the form of lower deductibles, lower copays, better managed premiums in good years.
Yeah, I mean, to me, when I hear the word rebate, alarm bells go off. Because a lot of times you'll hear a broker say, oh, well, you're going to get your rebates. And my first thing is, well, yeah, that's great. But as Dan pointed out, I'd rather just pay the lower price rather than give you my money for the next 12 months, right? Where you can make a float on it and maybe I'll get it back. So, so to me, when you hear rebates, I would suggest digging deeper and finding out why is it that you can't just pay less for the drug up front rather than waiting to get your money back a year from now.
And the big three PBMs are really deep into the rebate game. That's the core of their business. That's where they can make their profits on spread pricing. The smaller players in the PBM space are doing some interesting things in terms of being transparent and listening to the needs of the employer and the commercial plan. So if you're going out to bid, I would encourage you to look at someone outside of the big three.
Agreed. And so we're in the home stretch on the state of the healthcare industry. So as you might imagine, with this much expense going towards pharmaceuticals, the ratio is shifting in terms of where your plan costs or your plan expense or your plan spend goes. You know, in 1980, it was 97% that went towards medical costs, particularly hospitals. But as the years are going by, the percentage that goes towards pharmaceuticals is increasing quite quickly, with that ratio being 3 to 1 on average today. So the good news here is that there's innovation occurring within the pharmaceutical space. And so with innovation should come better and better health outcomes. But what's less good is these drugs are very expensive, especially when they first are launched, because the pharmaceutical companies want to recruit their R&D investment. And so in the short term, for many years, when they first come out, they're going to be really expensive and they're going to cost your plan a lot of money. Now, in theory, these better medications should bring down your hospital spend. It should mean that people are in the hospital less. But if they're both going up, hospital expense and pharmaceutical expense, then we're in big trouble. Like we talked about earlier, not all providers, or doctors are created equal. Some are high quality, some are not, some have poor outcomes, some have great outcomes. With a medicine, it's all the same, right? So make sure you are working with your advisors, with your partners, to make sure that you are getting those medications at the lowest price point possible. And we'll talk more about ways you can do that later. One more slide, and then we're going to transition. So this is a short list of what we're hearing from CFOs of major health insurance carriers or stop-loss carriers around the country. So United Healthcare talking about their loss ratios going up from 83 to 88% in 2024. Cigna seeing a surge in specialty RX and cancer claims in 24. They're expecting significant stop-loss increases. Look at Blue Cross Blue Shield of Michigan, posted a $1.7 billion operating loss in 2024, and they're attributing that to a sharp rise in utilization. Blue Cross of Massachusetts recorded an operating loss of $400 million in 2024, the largest in their history. So carriers are getting whacked right now, and they're gonna pass a good part of that across to you. I mean, they have two options. They have to bring down their costs. They have to do a better job of cost containment on claims, or they've got to charge more premium. So my guess is they can't move that quickly. So you are going to see likely significant increases this year, and be ready. And it's still uncertain how tariffs are going to play a role as well.
And the stop loss side of things for those of us that are self-insured, we've been experiencing that for the last 5 years. That's a really tough market, and double-digit increases are the norm.
All right, so we're going to make a shift here. We've talked about all the problems and where things are heading. So now we're going to start talking about some of the ways that you can get on top of this. What I'll say is most of them require more work. So these aren't easy buttons, but when you're talking about hundreds of thousands or millions of dollars in healthcare costs that you may be spending, it's worth it to put that work in, or even hire the staff to put that work in, because the cost of that staff member may very well be dwarfed by the amount of money you can save in claims. So one of the best things you get when you self-fund is complete transparency and control. So those are kind of your two key words: transparency and control. Those are the things that allow you to really start to grab a hold of the wheel and do something about this ever-rising cost in your plan. And again, self-funded plans do take more work, right? So if someone's trying to tell you they're real easy, they take work. You're going to need the expertise on staff or within your advisors team to be able to put in and manage one of these plans. So on the left-hand side, we're looking at sort of the health plan, big insurance model. Everything's locked up. You don't have any opportunity really to affect how claims are paid or adjudicated. You don't get any ability to pick the partners that are going to work within your plan, whether it be the PBM, as we talked about earlier, or the stop loss insurance or the cost containment that you might want over claims. The carrier controls all of that. They also control who you get pooled with. What other employers is your risk getting mixed in with? On the right-hand side is what we'll call the unlocked version, the self-insured version. Now, as you see there, we intentionally use the word partially. So employers with thousands upon thousands of employees may truly self-fund, right? They don't have any insurance. They're just paying all the costs to administer the plan and for claims themselves. They're self-insuring. Most employers, particularly those that are under thousands of employees, are partially self-insured. So they're buying what's called stop loss coverage to protect them in the event of claims costs going above a certain amount. And so I like to remind employers that you may have heard of bad experiences with partially self-funding, but if you set up your stop loss insurance properly, you can cap your risk, just like you can in a fully insured model. As you can see here, there are two different types of costs. One is variable costs, which are your medical and pharmaceutical claims. They're variable because you don't know what they're going to be. It just depends on what happens to your employee base throughout the year. Actuaries do a pretty good job of, based on demographic data, prior claims history, that kind of thing, they do a pretty good job of saying what they expect claims to be. But this part of your plan is variable. It's not going to be clear until the year is done. Then there are fixed costs. Fixed costs are those that you absolutely need to be aware of and know what you're paying for the administration of your plan, the stop loss premium you're paying, what you're paying your broker, so on and so forth. When it is a partially self-funded plan, it's your plan, it's your data. Generally speaking, you have the ability to pick your partners or have some influence around your partner. You're not being pooled on a blind basis or an unknown basis with other companies that you don't know. And you even get the opportunity to participate in captives on the partially self-funded side, where you can choose who you're going to pool your risk with. So that's just a quick high-level comparison between the fully insured or even level funded type of model versus breaking the box open and setting up your own partially self-funded plan. Go ahead, Dan.
I would make the parallel that if you're fully insured, you're essentially purchasing an off-the-shelf product, right, with a fixed premium, whereas some of the benefits of self-insuring, as Adam hit on, is employer control. It gives an employer the flexibility with the overall objective of managing costs, delivering a valuable benefit to employees, which you would hope aids in retention and attracting employees. But there is risk associated with that. And I think it's important to point out again that employers bear responsibility for the cost and quality of healthcare as fiduciaries. And there are plaintiffs' attorneys that are out there that are making breach of fiduciary duty claims against employers. Two notable ones are Wells Fargo and Johnson & Johnson that have been in the news. But I would say if you haven't done so already, I'm sure most of the companies that are represented on this call have great leadership and good consulting firms working with them. Just make sure you have the processes in place to document your decision making as it relates to your benefit plan, to cover your bases and ensure that from a fiduciary perspective, your T's are crossed and your I's are dotted.
All right, so next slide. It is quarter, it's quarter of. So we are gonna go a little bit over time, but we'll keep things moving. But we, just so you know, if you have to hop off. This will be recorded, but we'll go a little bit past the top of the hour. So there are two basic types of stop loss coverage that you purchase within a self-funded plan. One is specific or spec, some people will say, spec and ag, specific and aggregate. So specific stop loss coverage limits your liability with respect to any one claimant. So typical specific attachment point might be $50,000. So you would be responsible for any claims for a particular claimant up to $50,000, and then the stop loss coverage picks up any claims for that claimant above that $50,000 stop loss attachment point. So that's where your limit of liability would come in on the individual claimant level. So an employer might say, well, that sounds great, but gosh, what if, I have a bad year and many of my employees go over that or go up to that 50,000? And what if I have, 20 people that go up to that attachment point? Well, that's where aggregate stop loss coverage comes in. This is a way to protect you or put a stop loss in place across all claims in your plan, such that if you have a really bad year, and a lot of people have a lot of claims and they all go up to or exceed your 50,000, that you've also got a limit, a total limit for the year on what you're going to pay towards claims. So those are your two basic types of stop loss coverage. Again, you can, through the aggregate coverage, cap your risk. There is also the consideration of runout risk if you were to move your plan. We're not going to get into that today, but that's another area to make sure you're aware of. Should you change carriers, make sure you understand your stop loss contract in what claims it covers over what period of time. So most of the savings is going to come in self-funding, moving towards that control and transparency model. And I always encourage people to think about how they can use some of those savings to beef up their HR teams to still save money, but make sure the transition to these plans goes smoothly. So I think, Dan, you talked about the next slide.
I did, yep.
So, keeping that sort of fiduciary responsibility that you have in mind when it comes to the payment of claims and those claims being reasonable in cost. So now we're going to jump into with the next slide, those things you can do on the medical or hospital side of things to bring down costs. Now, first and foremost, these are ideas. These are not things that Dan and I are saying everybody should do. These are ideas. This is kind of a shopping cart of things that you can consider for your plan. Many of these will not be good for your plan, just not a good fit, or maybe you've tried some of these things in your plan and they didn't work or they weren't implemented well. But your advisor should be talking to you about these ideas and these concepts to continue to find ways to bring down cost. So this slide is a lead-in slide to something that's called reference-based pricing. And over the years, it's got a little bit of a boogeyman reputation, but it is highly effective for the right employers. And here's where the problem comes in and why it can be a good solution for some, is that hospitals mark up their services over cost by quite a bit. If a hospital takes $1 of Medicare money, or money from Medicare, then it has to report the cost of all of its services and what they charge for all those services to the Centers for Medicare and Medicaid. So this data is public, right? And so what we're looking at on this graph of the United States is how much over cost hospitals on average in those states mark up. And so you can see in states like Texas and Florida and Nevada, 1,000% over cost is what they're marking up, how they're marking up. Now, obviously, if you are getting care through a network, then that network is negotiating with those hospitals to bring that cost down. And you'll see oftentimes about a 50% discount off of the service master charges we're talking about here. But then, in Texas, you're still paying, even with a 50% discount, almost 500% over cost. So that's the bad news. The good news is there's room to maneuver here. There's negotiation room, right? There's the ability to say, time out. Why am I paying 500% over cost or 300% over cost? That's not reasonable. So you can pick out your state here and see how bad it is. Next slide does a comparison between how claims get paid on a network-based plan versus a reference-based pricing plan. And so let's take an example of a charge master price of $5,000. In a network plan, again, typically the network negotiates about a 50% discount. And so a network plan is going to pay $2,500 for that MRI or whatever that service or care that was received by the employee. Or if the employee's got a $5,000 deductible, they're paying $2,500. On the reference-based pricing end of things, it starts from the bottom. That's why they call it a reference base. It's starting with either the cost of the care or Medicare as a reference point, and then adding margin to it and paying that for the care that was received. So in many of the TPAs, third-party administrators that manage a reference-based pricing plan will pay the claim either the cost of care plus 12% or Medicare plus 20%, whatever is higher. So in this case, the actual cost of the care was $250. The Medicare rate was $280. The reference-based pricing plan pays $336. So quite a bit less than what you would pay through a network plan. Again, ERISA requires that plan costs have to be reasonable. So this is where hospitals are faced with, do they want to face an ERISA lawsuit, or do they want to agree to pay or agree to receive the reference-based pricing payment? The downside can be is that there can be some back and forth with that hospital, negotiating, and the employees in the meantime waiting it out, right, or getting balanced bills, right? So there can be some employee disruption when you offer this type of plan. What's important is whoever's going to do this for you, that they accept the role as co-fiduciary over paying claims. So that it's not all you, it's also partially them determining what gets paid. On the next slide, we'll show a couple of examples here between different hospitals in Philadelphia for an MRI. So you can see that the price that the hospital charges, let's take the middle option, is $3,800. The average cost for an MRI is $75. Medicare pays $125. So if you're going to pay for this service through a network plan at a 50% discount, it's still $1,900. In an RBP plan, a reference-based pricing plan, that would be $150. So much more likely that your employee is going to get that care because they can afford it, rather than put off care because they can't swing $2,000 right now. Go ahead, Dan.
It's amazing when you look at this slide, you know, the markups are just crazy. But I will say that reference-based benefits, it's a disruptive approach, and one that it appeals to me and my inner curmudgeon, just kind of saying, all right, this is what we're going to pay, you take it or leave it. But one thing that we think about, and I would encourage employers to think about, is your corporate culture, number one. The US healthcare system is not simple. I do have some concerns about an employee or patient's ability to navigate a health system that is exceedingly complex, and health systems such as ours without pre-negotiated rates, you know. So I really do think you put employees in a tough spot to get balanced billed by a health system or a hospital. But what you're seeing with these TPAs is that usually if you go in a reference-based pricing arrangement, you'll have a layer of advocates or administrative support that are really necessary to deliver the kind of experience that many employers want to provide to their employees and their families. And that comes with a cost, but as you can see, there's a lot of savings there. So, you know, it is attractive, and I would love to get to a place where I do that, but I'm not there yet.
Well, if you think about this savings for one treatment, extrapolate that over all of your claims and imagine how much could be saved. But, you know, as Dan pointed out, there's the potential for balanced bills. There's the potential for your employee showing up for a treatment and having a problem with the front desk. You know, there are employee disruptions that can occur. as you said, Dan, the key to it is for your employees to call the TPA first and be navigated to those hospitals or facilities that they know will take the reference-based price because they've been taking it from us for years, right? So
Right.
when the employee goes off on their own, then that's when challenges start to come up.
I would also opine that, construction companies are not anxious to add to overhead. And it's just the way we operate. And you would need to add, you would probably have to multiply your benefits HR staff by 2 or 3 to manage a reference-based benefits plan.
Yeah, depending on the size of your company, you might want to consider taking some of the savings, which will be significant, and hiring someone to help roll out, educate, and handle issues that come up. So next slide, Maddie. Okay, Dan, we're going to talk about high performance networks.
Yeah, high performance networks are conceptually really great. And, most of your carriers, the BUCA carriers, have high performing networks. They can introduce some dynamics that complicate decision making. Think about someone in your C-suite that serves on a hospital board that is no longer in your high-performing network. That could be tricky. But conceptually, if you're going to limit your network to high-performing hospitals, and those, in my view, are ones that deliver the best value, again, cost divided by quality, I think that makes good sense based on the analysis that I've done with our carriers and potential carriers over the last 5 years on these high performing networks. The potential savings that a plan could generate by participating in one of those, I think, is outweighed by some of the negatives. And in our view so far, the juice hasn't been worth the squeeze. But I certainly encourage carriers, the BUCAs and others to cobble together these networks that are truly high performing, that can bring value.
Yeah, I mean, it's supposedly different from the traditional way of forming a network, which is access, 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 right? I want to provide everybody in the book so my employees are likely to find their doctor, right? But when you do that, you've got high cost, high quality, low quality, everything in between, right? So at least in theory, a high performance network is trying to say, this is not the Statue of Liberty network. This is, hand-picked set of providers that we know provide great care at a low cost. But as you say, Dan, it doesn't always work out that way, but it's worth looking at. There's also the ability to form direct contracts. So your third-party administrator should have the ability, or may already have, direct contracts with hospitals in your local area where they've already got a negotiated price that's closer to Medicare or prearranged. So keep that in mind as well. Next slide. So this is an interesting development over the past many years, and I bet you many of you have experienced this, that the cash pay rate at the front desk at a provider is oftentimes quite a bit less than what you would pay through your insurance. In some cases, that cash pay rate is even less than what that provider takes from Medicare. So there's been quite the growth in recent years in what are called bundled cash pay platforms. So through these platforms, you can get access to surgery centers, imaging, lab work, mental health providers, physical therapy and chiropractic care. All of these on these types of platforms would be at a cash pay rate. And so to the extent your health plan can tap into these cash pay platforms and give your employees access to them, then your plan costs are going to go significantly down because you're paying a cash pay rate. Bundled surgery centers have grown like a weed. Bundled surgery centers, I would call, are like a Happy Meal for a knee replacement, where you show up and they give you all the costs. The surgeon, the anesthesiologist, the facility, the hardware, all the things that you get 10 bills for are all rolled into one statement, one Happy Meal price. And they do a ton of these surgeries. So rather than a hospital that does 2 a month, surgery center does 10 a day. And so they're efficient, they have phenomenal outcomes, they have great data, they're clean because there's no cross-contamination. And in many cases, employers will fly their employees to the bundled surgery center because they're saving $30,000 on a knee replacement. So bundled surgery centers are where most of the savings can be gained, but across all of the services that you can find on cash pay platforms, there's a lot to be saved. Let's face it, hospitals like cash. They would rather get paid now, right, than wait for 6 months to maybe get paid or fill a bunch of paperwork out and hire a bunch of people to try to obtain the amount from the insurance companies. So keep bundled cash pay platforms in mind because there's a lot to be gained there, and the service and quality is as good or better than what you might see from a hospital. Next slide. This is one of my favorites. I think, Dan, it's growing on you too. I've been a member of a direct primary care practice now for about 5 years. So there's been a shift in many years of doctors have grown sick and tired of seeing 20 patients a day. They've got a back office of 12 people that are filling out forms and trying to get claims back from carriers. And it's no longer about patient care. They usually see a patient for 9 minutes at a time, right? And so a lot of doctors have broken away from insurance and they've established their own membership model where they charge you or your employee a fixed amount per month to belong to their practice. And you can cost share with the employee. You can pay half of it, they can pay half of it, but you have a real doctor. You have them on call, you have them on chat. When you go visit with them, you see them for 1 hour or more at a time. They cover all of your risk factors while you're there. They are your health coach. It's back to what real doctors like to do and used to do. In the underwriting, what we're seeing now is as much as a 20% credit in the underwriting, 20% decrement off of what the stop loss would cost if your employees have access to direct primary care. There's also the virtual side of that too for companies that are in rural areas that want a one-to-one relationship with a doctor, only in this case over a teleconference or video conference. So this has been transformational for me. My DPC keeps me on track month over month. We do multiple blood draws. We're constantly checking on my health throughout the year. Dan, I think you rolled out direct primary care to at least one of your divisions.
We did, yes. So we have a partnership in the Houston market with a direct primary care vendor, and it's covering roughly 3,200 patients in the Houston market. Turner covers the membership fee. The employees and their covered family members have access to over 20 different locations in Metro Houston. Now, it could take you 2 hours to get to one of those locations if you have to drive across town, but generally speaking, access has not been a problem. And for our business, primary care is super important, and encouraging people that work long shifts, maybe can't get to a traditional doctor's office during business hours, they can get preventive care and primary care after hours on the weekends. There's chronic disease management is a piece of that, and we're working with the vendor right now to put together some metrics to track how different disease states are being managed for our population. And as we compare this year, going through half of 2025 compared to half of 2024, our costs for that region are down 19.5%. And that is inclusive of the fees that we pay to the direct primary care vendors. So I'm a big believer in it. Of course, the proof is in the pudding, and I need to watch my figures, watch my data, and make sure that is continually effective. So yeah, I'm a big fan.
If they're keeping your employees out of the hospital and off of medications, or if they're on medications, they're keeping them in compliance with them, I mean, there you go, right? That's already worth the price right there. And this is not concierge, by the way. Concierge oftentimes is the doctor takes insurance and takes a membership fee from you. This is no insurance, you're just paying a membership model. So
I have a different opinion of concierge medicine, but we'll save that for another day.
Right. I have a feeling I know what it is. So moving on to the next slide. As we said, pharmaceutical cost is becoming a bigger and bigger share of what you're paying in your plans. A drug is a drug in many respects, so make sure you're paying the least amount possible. So let's talk about some of the ways that you can obtain drugs for your employees. I think, Dan, you were going to start on the far left. So each of these boxes represents a different way to source medications, with the ones on the far left being the ones that save you the most money, over to the right to the ones that don't save you as much.
Yeah, so patient assistance programs are, most simple when you're considering the uninsured or the underinsured, and that manufacturers can assist a person with in receiving drugs that are beyond their means. Essentially get them coverage with no or very little cost. When you talk about employer-sponsored plans, it gets a little bit more challenging. However, a patient produces a coupon or card when filling the drug, which is going to pay all or a portion of that copay, with the employer not having to absorb the full cost of that medication. It is attractive. We have worked with our other vendors, our PBM vendor and consultants, on some of the other solutions that are here on this slide. Copay assistance programs, those can be somewhat attractive. They can achieve savings, but I think that could potentially blow back on a plan sponsor after the assistance is exhausted, and plan members are then forced with potentially huge out-of-pocket expenses that have not accumulated towards their deductible on their medical plan. So I think, those are the two that I have the most experience with. Some of these other programs, I know, Adam, you have a lot more familiarity, definitely on the international side.
Yeah, I mean, to put a real fine point on it, we've probably seen this, many of you, in the news. We're paying 8 to 10 times more for the same drugs in the United States as compared to Canada or the United Kingdom, or Germany or India. So we are, in many ways, the innovation engine for pharmaceuticals, but we're paying a huge price in the United States for this. And President Trump, I think, recently came out and said he's going to make sure that Americans don't pay $1 more than what other countries pay for the same drugs. I don't know how he's going to accomplish that, but there's a massive differential. And so to the extent your PBM can source medications, especially these specialty drugs that are, hundreds of thousands of dollars a year, if you can source those internationally, you can save your plan a lot of money. So let's go through some examples. On the next slide, this shows the impact of PAP, or Patient Assistance Program. The employer would pay the $40 to fill out the paperwork to apply for the PAP money. And obviously, to the extent you're getting the medication for free, then your plan is saving a ton of money. And sometimes the employee doesn't qualify for medication for free, but they do get assistance. And so it still knocks the price down sometimes quite a bit. You wouldn't charge your employee anything out of pocket, because the plan's getting the drug for free, of course, or at a much reduced rate. So don't charge the employee anything. Generally speaking, individuals who are making up to about $48,000 to $50,000 a year can qualify, or for families, couples that are making up to about $65,000 a year can qualify for medication for free or with a lot of support. There's a lot of differences from one drug maker to another. So you can go directly to the drug maker's site, manufacturer's site, or I just found this site the other day, Dan, called, it's a weird name, it's needymeds.org. And you can put the drug in and it'll list out all the patient assistance programs that are available to the manufacturer for that drug.
Interesting.
So that, so needymeds.org is a way to see where you might be able to help your employee get access to a patient assistance program to greatly reduce or completely cover the cost of the drug. The manufacturers are required by law to set aside funds for this very purpose. So the money's there. You can hear it in the disclosure in the ads that are on TV. So this is a no-brainer, folks. If you have employees that qualify, use PAP. Next slide is a simple example of how much savings you can see from what you pay in the United States versus what you might get that drug internationally for. So we're talking 80, 85, 60% savings over what is paid for in the United States for the same drug. So international sourcing is something I would suggest to you, you've got to take a look at. If you look at the next slide, this is the list of drugs and what were paid for them for a 200 employee contractor in Tennessee. 200 employees, they're paying several $1 million in premium, but what they paid for drugs was $853,000. We ran a reprice on those same medications, and we're able to save this contractor $647,000 on their spend on medications through using things like PAP and international sourcing and copay assistance programs. That's a massive differential. So, what does that tell you about Blue Cross Blue Shield of Tennessee, right? How aggressive are they being about finding medications at a lower price point or helping employees fill out the paperwork for PAP? They're just not doing it. So this is a huge cost-saving area, and you can obtain this information through getting a reprice. If you're looking at a new PBM or a couple of new PBMs as a possible solution, ask them to reprice what you paid for your medications in the prior year and have them show you what that would look like if they did the PBM work, if they obtained the drugs for you. See if they'll put their fee at risk. Right? See if they charge on an admin fee basis or a spread basis. Right? Understand how they're making their money. There's a lot to be saved here. So we have just a couple minutes left. Dan and I will shoot through just two more concepts and we'll wrap it up. So next slide, we'll talk about member advocacy in terms of financial advocacy, but then also care advocacy, if you will. So on the next slide, there's a little known section of the IRS code, section 501R. And this requires that nonprofit hospitals set aside money to help lower income individuals with their out-of-pocket costs. Most of the for-profit hospitals follow suit. They also put funds aside for lower income individuals. And as you can see on the next slide, there's a set of hospitals here in Florida, as for example, even employees that have household income up to $100,000 can get partial relief through this 501R money. The trick is you need to know how to get to it. You need either your third-party administrator or someone they work with who can fill out the paperwork and obtain these funds for your employee that'll cover their out-of-pocket costs, their deductibles, their copays, out of their co-insurance. So 501R, that's the thing to remember, and start asking around about how you help your employees get access to those funds. Next slide. Care navigation is huge. We don't have time to drop into it, but nowadays, care navigation is one of your cost containment tools. To the extent that care navigation team that you're using at your TPA or at your carrier is guiding your employees to high quality, low cost care, then the navigation is working. They're also a way to level up the customer service your employees get. If they have care needs, then it helps guide them through their care, make sure that they stay compliant with their medications and achieve better outcomes. So this becomes kind of the quarterback for your employee to find doctors, set appointments, work through care, help with compliance on meds, all of it. So this can be the linchpin for many of you in your plan if you have access to a good care navigation team. Some companies even hire a separate care navigation team just for their workforce. So Dan, I don't know how you handle care navigation, but I think you'd agree this is a pretty huge way. Yeah.
Without question, I know we're short on time, but we've had a really good experience with care navigations. We partner with health systems at the local level in 5 of our markets to have a nurse come to our job sites and navigate care for our employees. And the motivator behind that really was management of chronic disease. That was top of the list back in 2010. when we started these partnerships, but it's really built into managing high-cost claimants, directing care to the providers that are best qualified to do a certain procedure. And it's incredibly well received by our population. And I think my organization's unique in that employees like to see someone on site. They want to see them in person, sit across the desk from somebody and talk to them about how to best manage their individual health. So yes, it's been extremely beneficial for Turner Industries.
Next slide. Maternity advocacy doesn't seem like a big deal, but if you get just one preemie baby, if you have one baby that gets into the NICU, you're looking at massive cost to your plan. And what is clear from the data that we've seen is most NICU events are avoidable. It's a matter of making sure that the expecting mothers get the kind of education they need in the beginning and throughout their pregnancy to make sure that pregnancy has the best outcome possible. So be sure to ask about maternity advocacy and promote it. The average NICU cost is $160,000, and it can range up to as high as $1 million to your plan. The hospital cost for NICU is anywhere from $3,000 to $60,000 per day. So you want to do everything you can to avoid a NICU or a premature birth, and maternity advocacy cuts that risk way down that it's going to happen.
Adam, I'd love to see that information on the avoidability of NICU. That's really interesting.
Yeah, and there's a couple of third parties now that are specifically you can bolt onto your plan.
Yeah, and I can jump in on this one first. Eligibility management is really important to any plan. You can look at finding risk on your plan that can either be removed altogether. Someone's not eligible to participate in your plan based on your plan rules, or managed. And one of the things that my team and I do on an annual basis is conduct a dependent audit to ensure that my team has documentation that authenticates someone's eligibility to be on our plan, whether that's a marriage certificate or a birth certificate or court paperwork, divorce decrees, that kind of thing. That is really important for us, and we catch a number of folks on these audits that we would not have caught without doing these. We've also implemented some procedures on the front end to ensure that people that aren't eligible don't end up on the plan in the first place. There are a lot of vendors out there that do this, and one thing that you think about as you look at the cost of health insurance plans is the expense for a spouse. And Adam can touch on this. I know we talked about it the other day. Spouses really drive the cost of a health insurance plan, and employers are put into a position of determining whether you impose a surcharge for those insuring spouses that may have access to coverage elsewhere, or do you simply structure your premiums in a way that serves as a de facto surcharge, right? And like the line at the top here says, it's a decision of eliminating risk or managing it more effectively.
Yeah, for whatever reason, spouses cost 50% more than your employees do, and it doesn't matter male or female. So it's kind of a fascinating part of underwriting. So to the extent you can design your plan in such a way where there's either they're not, spouses aren't included in your plan if they have coverage elsewhere, or like Dan said, there's the ability to charge more when spouses disproportionately more when spouses take coverage. Those can be ways to remove the risk as opposed to having to manage it. And then once an employee reaches age 50, the costs go way up, way up. And so to the extent you can structure bonus programs that start to provide, let's call it incentive, a bonus for employees over a certain number of years of service to go get their own coverage outside of your plan, that's another way you can remove risk. And there's some clever ways to design those bonus programs to get those older employees off of your plan, but onto something that is probably even better for them, more suitable to their needs. And then further to that, the Samaritan Fund on the next slide is something to consider in that these are for the really hard cases, for the employees who have terminal cancer, significant transplants needed, really expensive medications. There's an organization called the Samaritan Fund. And there's a simple application process we go through, but if your employee qualifies for the Samaritan Fund, they pay for all the premium, all the out-of-pocket costs. They even work with the employee as a care navigator to help them through this really difficult time in their life. And meanwhile, they're not costing your plan millions of dollars and driving up your health plan costs for all of your workforce. So the Samaritan Fund can be a lifeline for the employee and for the employer when you just have a really hard case. So that about wraps it up because we're way over time. Two other things Dan and I would like to talk about in future sessions is how healthcare captives are on the rise. A lot more folks are adopting those and pooling risk with fellow contractors. The ABC has a healthcare captive that we offer nationally to members, and so it's a way to become part of a program that drives costs down. And then there's something called individual coverage health reimbursement arrangements that are also on the rise and provide you ways to take employees off of your plan again and onto individual coverage that might be more suitable for them and drives your cost way down. So with that, we're going to wrap it up. Here's Dan and my contact information. Please feel free to email one or both of us. We'll also send a follow-up email with a landing page where you can submit questions or ask for help from either one or both of us. And so with that, thank you everybody for joining us today. It looks like a lot of folks stayed on. We really appreciate that. Dan, thanks for being my teammate today.
Glad to do it. Appreciate it.
Looking forward to the road show. And
Me too.
Derek, I think we'll let you take it from here.
Thank you. We're out of time for today. On behalf of ABC, I would like to again thank our panelists and also our strategic partners, CNA, the Contractors Plan, JLG, Milwaukee Tool, Procore, Southwire, Tradesman International, and United Rentals. This webinar will be archived on the ABC website, abc.org. Attendees will also receive an email within 24 hours with the link to the webinar recording and presentation. Today's webinar is copyright 2025 by Associated Builders and Contractors with all rights reserved. Thank you again, and you may now disconnect.
Thanks, everyone.